Hi everyone. Thank you for letting me come into your facility. I am Bonnie Hunt. I'm with Zynex Neurodiagnostics out of Denver, Colorado. And our neurodiagnostics arm is new this year, started in January, but this device that I'm going to present to you today, the NeuroMove, has been around for about 6 years. It's a very exciting device which promotes neuroplasticity in your stroke, your traumatic brain injury, and spinal cord injury patients, as well as other orthopedic paralysis. And so I'm really, really excited to talk to you about it. I've actually talked to a few of you one-on-one, and which is the reason I'm here, but hope you enjoy the lunch. And the first thing I'm going to start with is a PowerPoint, just to kind of familiarize you guys with the dynamic behind it. And then I'm going to actually do a hands-on presentation with you to show you what this thing really is all about, okay? So I'm just going to go through the whole PowerPoint, and I'll expand on it as I go. We won't just read everything line for line, but if you have any questions along the way, please stop me. If you want to, just raise your hand or something, I'll be looking up, talking to you, and I'll be happy to, talk to you about anything. So the NeuroMove is an EMG triggered device with NMES as a reward built into it. Relearning tool for stroke and other brain injury paralysis. Obviously, who benefits from the NeuroMove are these stroke patients. It's the #1 treatable paralysis in the world, and we get a lot of the same results with traumatic brain injury, palsies, congenital paralysis, spinal cord injury. I have other hospitals that are using these specifically. In some groups, just for palsies. I have a pediatric hospital in New York that uses a device for cerebral palsies, and they're having great success with that. Obviously, for pediatric patients, the patient has to have a couple criteria before we can, do the device, which I'll go over with you, but really good success. So we have evidence-based successes, peer-reviewed clinical trials. www.neuromove.com will scoot you over to www.zynexneuro.com, which has a whole lot of information on it for you to check out. If your patients want more information about it, they can go there as well. We at corporate are happy to talk to any of you about any questions, problems, or issues, and we're here 5 days a week, all day long. My cell phone's going to be available for you. I know you guys are on Eastern time, so that doesn't make any difference to me. You can call me. We have patient testimonials on there, as well as rehab hospital usage protocols. There's also the PowerPoint on there, so that if you yourself want to refresh on the PowerPoint, you can go on and look. So one of our clinical studies on chronic motor dysfunction after stroke concludes that 2 lines of evidence clearly support the use of EMG-triggered NIMS to rehabilitate wrist and finger extension movements of hemiparetic individuals post 1 year after stroke. That was by Dr. James Carraw, who has been a proponent of the NeuroMove for many years. He's still doing studies with the NeuroMove at the time. Conclusion was progress often far exceeded that of previous conventional therapy. Regarding mechanisms, impaired proprioceptive feedback is considered central to stroke disrupted sensory-motor control. EMG-triggered EMS is intended to improve brain relearning by reinstating proprioceptive feedback time locked to each attempted movement, and our clinical results were consistent with that theory. Basically, what that means in a nutshell is this device, through its ability to promote neuroplasticity, and through repetition after repetition of the cycle of therapy, really locks in place that rewiring process that is necessary for the good neurons to take over for the bad neurons that were damaged. We are FDA cleared. We're also cleared by European health standards. We have the NeuroMove all over the world right now. So these hospitals that are listed here, in the very beginning, we directed ourselves to patients, and so we actually took the NeuroMove into big hospitals and we asked them for free to trial the devices, and we taught them how to use them on the patients. And we said, you know, please try them on as many patients as possible so that you can see what we know this device can do. And then if you believe in it and you want to use it, please do and prescribe this for patients so that when they go home from these traumatic injuries that they have some hope at home for some movement. So big name hospitals, Johns Hopkins, RIC, as you know, is one of the mainstays of the whole therapy industry. Mayo, Kessler, Lutheran, and they're still using them today, and they're actually purchasing them from us now. So the Lutheran Rehab Hospital, their director there has been a huge proponent of this from the very beginning, and they actually developed a Retrain the Brain program built into their therapy program. As you all know, a lot of standalone rehab hospitals and outpatient centers have FIM scores that they have to meet, and it's packed in the day. So to fit a 20 to 30 minute session in to work this into their rehab is difficult. So we actually would like to see you build this in so that 3 to 5 times a week you have the ability to do this therapy on the patient. So obviously for acute rehab, outpatient rehab, and home care therapy. So we gear ourselves to you, the clinicians, because we feel like you, the clinicians, are the ones who can truly get the movement back properly. The device is helping get the movement back, but you can get good form in the movement. And so we feel like clinicians are an essential part of this whole piece of the rehab process. So then, you know, if you get to the point where you really still want the patient to have it and use it at home, we actually have a program here. Our company really doesn't make money off the patient doing this, but we do it as an addition to your services. So we have a program where the patient needs a prescription from the doctor, so that's one thing that you, the clinician, would have to facilitate to get for them. But then they would call corporate. We'd have to have a little bit of patient information so that we can contact the patient and arrange our payment plan with them. Payment plan is not covered by insurance. It is covered for your therapies at an average of about $115 per patient per therapy session. And we have 3 main codes that are used in order to get that payment. But as for the patient themselves being able to have it covered by insurance, it isn't. Insurances aren't progressive with current technology, and they're way behind the times, as you all know. So it would be $165 for the first 3 months for the patient, and then $99 after that if you wanted to have that for the patient at home. We totally work with them on that. At any time the patient would like to send it back, and the payments will end, and we'll actually send them a label to send the device back. So it's really easy for the patient to say, you know, I don't want to use this anymore, but also use it for 6 months or a year if they want to use it, you know. And they've had your teaching to be able to know how to keep working on what you've started. So that's kind of the setup of what the initial therapy for hand looks like. Everybody here, how many of you actually do hands-on with stroke versus spinal cord injury patients? Does everybody here work with stroke patients?
Yes.
Pretty much, and spinal cord injury, so it's kind of a group effort?
Yeah, quite a bit.
Okay, so you all know what neuroplasticity is. Basically, it's taking that plasticity by driving the healthy neurons to take over for the damaged neuron and regaining voluntary contractions. The patient imagines the movement is rewarded through stimulated contraction, which equals movement. I actually had one of my reps out of New York, who actually Chicago, I'm sorry, did a presentation for a big group yesterday, and they had a patient that they were getting ready to discharge. He was a stroke patient, didn't have a whole lot of extension. He hooked him up to that NeuroMove and got huge extension. He said, you should have seen the therapist's eyes, it was amazing. And so it's like, yeah, I know what that can do, so it's great that you're showing them that and that they can actually see what the device can do. And I actually have literally hundreds and hundreds of stories like that from therapists, from patients' family members. What makes a successful brain learning tool? Okay, so there's 2 criteria. The patient, once they're stable, needs to be cognitive, so they can actually understand what we're doing. And then they have to be able to concentrate for 20 to 30 minutes. Generally, in the very beginning of therapy, I say, try 20 minutes, especially for a stroke patient. They're sick, and they're just getting back on their feet again. And 20 minutes of trying to imagine your hand or your foot or something doing that is a lot of work for them, and it is for paralysis patients too. But once they actually see some movement and coming back, they're very excited about it, sometimes very emotional about it, and I end up being emotional too when I see it. I end up crying with them. I can't help it. It's just such a moving experience. But they can actually feel the hope of maybe being able to use their body again that, maybe they've been told is not going to happen for them. So it really, really, really does give patients hope. So that rewiring process through focused repetition is what really establishes that brain plasticity take place. So the EMG detects the targeted neurological attempts to move the muscle, and then by utilizing repetitive attempts, it rewards through neural remapping. I'm really sorry, I'm kind of a dork when it comes to these. It's like my mouse is on the arrow, but then I move it and have to come back to the arrow, so I apologize. Patients can experience immediate results. So, just an example of what I just told you about that patient yesterday. They couldn't get him to get extension like he got with the NeuroMove, so that was immediate for him. That's what your patients can see when you start working with them with this. So that doesn't only give your patients hope. Man, that word of mouth goes all over the place for you as the therapist too. So, if you guys decide to buy this device, which I feel like at the end of 30 days and you've used it on as many patients as you can, you're definitely going to want to. Feel free to advertise that you have this. We're fine with that, to be able to get more patients into your facility through the idea that they can have a better prognosis for their incident. These are really contraindications instead of precautions, but obviously pacemakers are something that you need to get approval on. We really don't feel like it is an issue, but once you have the approval, then you can go ahead with it. Epilepsy, through the really concentrated effort, we feel like sometimes it might be a possibility that it might stimulate an epileptic attack, so we stay away from that. Obviously, so this device is EMG driven with the NIMS as a reward. It's not part of the actual reason that this remapping, the actual targeted attempts are picked up, but it is through the reward process. So we don't know if E-stim actually excites cancer or not. We stay away from that. And of course, first trimester of pregnancy is something everybody stays away from. But E-stim is used on, full circle patients that are having babies for pain. So we just feel like first trimester is the one place to stay away from. In the kit that you have, or that you'll get for this trial, is the electrode placement guidebook. Helps you know where to place them. The places that I feel that therapists have the most problem with the placement is for shoulder subluxation. It gives you a really good guide of where that is, but it's just a real fishing expedition per the patient's anatomy. Kind of got to work with it a little bit. And you want to get a really good contraction so that when they're working, it pulls them up and they can actually get a good shrug out of it. I tell patients when they're trying to do that to maybe think about shrugging into a jacket or reaching back to do something that you would do with your shoulder to imagine. So when you're working with patients and you're thinking about what do I have this patient imagine, a lot of times you just want to talk to the patient and ask them what they did before that they can't do now that they want to do again. And that will trigger all kinds of things for them to imagine that they want to do. When I have it on, I imagine imagine spiking a volleyball because that's a real visual thing for me, and I can really get some good, movement out of meeting the threshold. So there's an instructional DVD. There's an AC cord for recharging. That device needs to probably be recharged, say on a Friday when all your therapists are leaving for the weekend. Go ahead and plug it in and recharge it, and then it'll be ready on a Monday morning for your therapies again, once a week. It can't be used plugged into the wall, so it needs to be charged and unplugged. There are 2 connecting lead wires. The reason there are 2, basically our engineers say that those lead wires are tough enough that you can hang from the ceiling from them, but somehow in the past there are a few therapists that can break them. So I always have another one in there for you so that the continuum of care, you don't lose any time with your patients. And there's a program manual as well. So the typical therapy session setup is to attach the electrodes to the muscle group that you want to work with first. Then you turn on the unit, then you set your E-stem for a comfortable yet comfortable visible contraction. It's going to buzz, but it's not going to hurt unless you get it too high. If the patient's really saying it hurts, then you've got it too high. But you want to get a nice contraction, and I'll explain that once I give you the actual hands-on. It can be used on any group of muscles: the wrist and finger extension and flexion, front and back elbow flexion, shoulder subluxation, abduction, ankle dorsiflexion, knee extension, and I was going to continue on with shoulder subluxation. Ankle dorsiflexion is another area where per anatomy, you're just going to have to fish a little bit to get just the right thing to be able to get a good dorsiflexion. Starting points: upper or lower extremities, distally or proximally. So the book that comes with it, that's kind of what it shows you in the book of where those placements are to give you an idea. Therapy session overview. Cycle of therapy is very start of it. The NeuroMove is setting the threshold. I'll explain to you what that threshold is when we do hands-on. The ready, when the patient makes the attempt, when they're actually closing their eyes and really trying to visualize whatever it is that they want to do with their hand or foot or what have you. And then once they meet that threshold and it crosses, then they get that stimulation as a reward, and then it goes back to relax. I'm sure all of you have heard of Pavlov's dog. That whole theory with the reward in this device is all part of that Pavlov's dog theory of a reward process. The brain recognizes the reward, and it's all part of the rewiring. We feel like it's an integral part of it. So I feel like sometimes when we're talking to therapists, they get confused that this is an E-stem device, but it only is an E-stem device in the NeuroMove setting. Let me back up for a minute. There is a stem-only section on this, so you can use this device as a NEMS. It'll turn off the EMG part of it, and you can use it as a NEMS, and I'll show you what it does. But in the stroke mode or the spinal cord injury mode, it's simply just the reward for meeting that threshold. And then it goes back to the relax, where the patient is in deliberate rest. And the difference between the rest and the attempt should be very vast. It's important to have really good relaxation and really active imagination. Those differences are really going to lock in that rewiring process. So sorry, where is it? The processor begins to, see, if I didn't use my hands to talk, I could leave it there all the time and then I wouldn't have this issue. The processor begins to detect the EMG and set the threshold. Those lines up there are the threshold. It starts up high and then it adjusts very rapidly down to what that patient's level. So those lines up there, that right-hand line, probably when they first started it, the patient was not in a calm state. So they got to where they were. I have the patient just start breathing in and out and focus on the breathing, have their hand relaxed or their foot relaxed, and just probably for the first couple minutes, just doing that to get nice and relaxed. The more level that muscle noise is, and the lower it is, the better. But the threshold will adjust down to not be too difficult for them to reach. It's adjusted up or down every 15 seconds automatically. And then the patient makes the concentrated attempts in the ready mode to make muscle exertion sensors detect those real attempts. So those spikes in there are what the patient, when they're being told to concentrate and focus on the imagination part of this therapy, is when they're trying to reach that threshold. The threshold, as you can see on that picture to the right, they haven't got them thinking yet, but once they do, that level will rise up quickly to meet that threshold, and then once they cross it is when they actually get that stimulation. You want to encourage the patient to imagine or visualize movement, so have them close their eyes and engage the brain. I also find that sometimes actually seeing something in front of them is just as important. So you might have a patient that you want to put a hand right in front of them and say, I want you to try to reach up and slap a high five. Sometimes noise will stimulate the actual visualization. So whatever you can do as a therapist to engage them into their imagination to make this work better, be creative with them if they're struggling. Once they get the idea of the therapy, they usually can snap right along and get it. And the device will actually, as they go, will challenge them as they get easier, as their attempts get easier for them because they get it. It'll continue to challenge them, so it's a little bit tougher and tougher. Imagination or attempt strikes the threshold on the right, and then it triggers the physical movement, which is the reward. Then the cycle is repeated. Everything's just repetitive after that. Threshold is reset every cycle and moves up or down to continually challenge or encourage the patient. So, like I said, we do stroke, spinal cord injury, traumatic brain injury. We have a lot of therapists who've treated ERBs, Bell's, cerebral, multiple sclerosis. The spinal cord injury setting is 5 times more sensitive than the stroke setting. So obviously on a spinal cord injured patient, you're going to have a lot less signal. So it's made 5 times more sensitive to pick those up. I always tell therapists, if you have a patient who's been labeled a complete, just as a therapist, put this device on them and see if you get a signal. Because if you get a signal on a patient that's been labeled as a complete, what does that say to you? They're not a complete. There might be some small, hope for them to have some kind of movement. Are they probably going to walk again? Probably not. But if you give that patient some kind of freedom to maybe move their fingers a little bit, or whatever it is that you can do with them, they don't have it right now. So that's good. This is driving me crazy. See, it keeps slipping too. Troubleshooting, there is an actual troubleshooting section in that, and I always tell the therapist to please call us if you're having any troubles with it. We don't want you to stumble around, trying to fix this and this, and waste a lot of time when you've got a patient if you're having a difficult time getting it to run. Just give us a call, and we'll run you through the troubleshooting ourselves. And if it needs to have an engineer to look at it, to troubleshoot, we'll do that quickly. If there is really something wrong, we'll overnight you another one. We'll send you a tag to send that one back. So there shouldn't be any real loss of patient time. Post-stroke and spinal cord treatment may begin once the patient's stabilized. It must be cognitive. And we have studies up to 30 years post-stroke, but I feel like if there's healthy neurons, there's hope for movement. The problem is with post-stroke, several years out, the latest I've ever worked with a patient is 12 years out, is that they've got their hands all curled up and they probably are dragging their feet. So some therapy needs to take place before you can actually start this process. So I work with a patient and another therapist to kind of pull the patient's fingers. It took us about 20 minutes to actually get his fingers spread out because it hurts them. You have to really take time. They haven't opened their hand up. But during that time, we actually got his hand open. We paddled it so it stayed open, and we used some tape on it. But when we started the process, he actually got some extension from it. So he wouldn't have been able to do that. These muscles are are pulling and there's no hope for being able to do that. So that's an important part of it as you as therapists, but that's what you have to do to get them started, but it really does even help those patients. So just an idea of what you might have to do. Treatment time is 20 to 30 minutes each session. Once a day building, 2 to 3 times a day. This would be for the patient that takes it home because you won't have time for that. Expect 4 months to a year treatment plan. We feel like the rewiring process really begins to be permanent at about the 2-month mark. So that means what you've worked with to get them at, there's not going to be any retreating going on. It's going to be pure work from there. What they have is what they'll keep and what they can continue working on. Can be used with Botox. I have a doctor who on ankle dorsiflexion will actually inject the calf muscle so it's real kind of paralyzed so that he can get pure movement on that ankle dorsiflexion. Baclofen pump, obviously you'll have a lot of patients with spasticity and so it's perfectly great to use with a baclofen pump. The NEMS it has programmable parameters when you put it into the stim-only mode. Obviously it turns off the EMG part of this, and so it's nice to know this is a very high quality, high powered NEMS that you can use on other patients as well as your traumatic brain injury, spine, stroke patients. With the programmable parameters, you can use it to treat muscle atrophy, reeducation, muscle spasms, and for pain. You can even use them on your patients that are having some pain before you actually do the NeuroMove treatment. It's not like regular biofeedback. Now, regular biofeedback, because of the way it's devised, it's got sensitive input, but the signals are filtered and averaged. With the design of the NeuroMove, everything is opposite. Obviously, since the sensitivity of the patient's much lower, so the way it's designed, it has very fast input circuitry, and it looks for a pattern in the small changes that detects the brain to muscle attempt so that it can pick them up. Regular EMG won't be able to pick that up. So that's why it's different. The other reason it's different is this is actually a 3-part biofeedback unit. You've got the visual, you've got the audio, and you've got the physical. There's no other device out there that is like this. And so a real effective demonstration of this is when I actually put it on you all who don't have any problems, at least that we know of. And then we have you imagine moving your hand without moving it. Has one channel. You can only use it on one muscle at a time, but you can, treat different areas. You just can't do them at the same time. BioNus, I think probably BioNus has maybe made some statements that they're like us, but they're not. BioNus is functional e-stim. It has no EMG in it, so it can't rewire. So a patient can be using BioNus. It's actually a device that goes onto a muscle group, triggers a muscle stimulation. I mean, only while the patient is using it will it be effective. Maybe over time some muscle memory will come, but it doesn't rewire, it doesn't become permanent, and it's not a neuroplasticity device. So basically when the patient takes that off, they're just going to be as limp and like they were before they use it. I'm not saying it's not a helpful device if you already have it to use with the NeuroMove, because anything that helps the patient have better quality of life is a good thing. Did you have a question?
Yeah, actually just a second ago you had talked about spastic patients, and I've got a patient that presents with a fair amount of spasticity. So if I were to put that device, say, on the right side, the affected side, and they have a lot of spasticity during the treatment on the left side, would that limit, would it still work? Or?
No, the electrodes are only going to pick up the muscle group they're over.
Oh, okay.
And so the patient can be spastic on this side and won't pick up that at all, so it's perfectly fine.
Oh, good.
Now, since you brought that up, I want to tell you that I have seen patients that sort of get into the mode of, trying to move their hand. They actually put their shoulder into it. So I tell therapists to just hold their shoulder back and make them only use their hand.
So they can't engage
right.
Because I do have a patient who uses his upper back a lot.
Yeah, just kind of isolate to make sure that they're not,
Okay. Got it.
yeah.
Got it. Thank you.
It's not complicated to set up. I'm going to show you how that happens. The settings are to basically, you as the therapist can change the threshold. If you've got a patient that's struggling a little bit, they're not meeting that threshold, and the device won't go lower than the background muscle noise is. So you might want to just incrementally take that down just a hair, and I'll show you how that works. 99% of the time, the factory settings are going to be perfect for each of these stroke mode for traumatic brain injury and stroke patients, spinal cord injured patients in the spinal cord injury mode. There is a way, if you have changed anything, to go back to the factory settings and reset it. The rest period can be changed. That's when you're having the patient relax and not think. In the ready mode, the patient can't trigger it by moving at all. And I mean, did I say ready? In the rest mode, the patient can't trigger it at all until it's in the ready mode. As the patient moves, you're going to, as they start moving, so in the very beginning you may have nothing, and then you start to get movement. The more you get movement, you still want that whole imagination process. You still want them to focus on what it is they want to do, but you also want them to get moving. So you want to encourage them to move with it. So it's not just always just still treatment. You want to encourage the movement and increase it as you go through the therapy. So the rest period is 15 seconds set into the factory settings. So I always tell therapists, instead of changing that, if you want them to continue to rest, just don't have them think about anything. Just keep them, breathing and not doing anything, because the device will not pick it up unless they're actually imagining it. I'll show you how that works, but they won't. So, I mean, I could have a patient still be breathing in and out and not doing anything for 5 minutes, and it won't pick up any brain activity until I actually tell them to start thinking about something. Then it will pick it up. You can set the audio on or off. Sometimes that's kind of critical for maybe a stroke patient, that it's a little bit too much stimulus. So you want to treat the patient in a quieter area so they can concentrate and not have a lot of outside stimulus, taking their concentration away. And there's a compliance data part of this, that if you actually end up getting one for a patient at home, you can have them come in, you can check how often they've used it, just if you want to know if they are continue the treatment at home. It's a good device, good tool for you as the therapist if they end up having it at home. The changeable parameters I'll talk to you about. The 2 sensitivity ranges, that lower, that 0.25 is actually a spinal cord injured setting. It's, as you can see, it's 5 times more sensitive, but that lower setting is the more sensitive setting. So that is the PowerPoint. We'll go ahead and get some hands-on. And if I could get a volunteer, we'll go ahead and set that up and arrange for that here in just a minute.
I'll give it a shot.
Thank you, guys. Okay, so why don't you go ahead. What we'll do is, after I put the electrodes on you, I'll just have you relax in your lap.
Okay.
Or maybe we'll leave it on the table, that way the rest of you can. Typically, when you're dealing with a patient, you would just have them relax in their lap. That's the most natural way. So we'll do it this way, and I'm going to turn this at some point so you can see it as well. But for training purposes, we want our other reps and people to be able to see what the difference is on the screen too. So
Okay.
So I'm just going to make sure electrodes don't like lotion, so we'll just make sure the skin's really clean. Now, each one of these electrodes can probably be used, they say up to 40 times. I think if you get 20 to 30 out of them, that'll be pretty good if you treat them right. So put a little water on them before you put them on the patient. Put a little water on them, get rid of the skin cells. When you put them back on the plastic and stick them back in that Ziploc bag, there's 20 that comes with this, so that gives you enough for 20 patients. So you can like put maybe first initial, last name, or however it is that you want to be able to make sure that patient's got their own electrodes. So you're not putting these on motor points, you're putting them on the belly of the muscle. So just put it, that's a really good seal, and you want all of the electrode to be nice and down around the skin. And if you have a patient with a real hairy arm, you're gonna have to shave them.
Okay.
So this is the ground. So these are the 2 that are going to pick up the signal. This is a ground that can either be here or underneath this arm up here.
Does it work with other electrodes if they're sensitive to skin,
We have sensitive skin electrodes
You do?
if you have, but I mean, I very rarely have anybody that has any problems with these electrodes. So if you did have a patient that did, we could get you some out, but these are really, I don't think I even have anybody asking
Oh,
for them
really?
actually. So,
Okay.
so basically, you're going to turn the device on. And typically we would go ahead and set the stem right now, but if she moves at all, it's going to pick that up. So I'm just going to go through the program and show you what's inside to change, and then we'll set the stem. So as long as you're hitting the program, that takes you through the whole entire options you have here. So that first, when it's in program mode, if you hit it once, it'll go to threshold. That's where if you want to increase or decrease the threshold, you can do it here manually. Here, press program again, you're in the rest period. You can expand that to a longer rest period if you want. Like I said, if you just want the patient to rest longer even when it's in the ready mode, that's an option for you too. Here's where you pick the mode. So it's in stroke rehab mode. If you hit the arrow up or down, it'll get you into the next, which I'm in the stem only mode right now, so that's turning the EMG part of it off, so you wouldn't be able to actually engage the NeuroMove in the neuroplasticity process, or the spinal cord injury mode. So this is where you would do that. Hit the program again. This is where you can change the parameters. Anywhere you see a down arrow, you want to hit the down button once, and then you go back into program to go within that area. So it's showing to change parameters the down arrow. This is where you can change the frequency, the pulse width, the stem period. The stem period is going to be 5 seconds. If you wanted a shorter or longer, I don't know why you would want that. The ramp on and ramp off time for the NIMS, the range, and the treatment time. And then if you hit it one more time, if you had changed anything, that gives you the factory defaults, and it's asking you, do you want to set the defaults? Showing you the arrow, that's where you would hit it, and then the defaults are set, and it tells you defaults are set. Then you hit the program again, and it takes you next. You're kind of out of that parameter loop, and it tells you how much battery you have. You need to be at 80% or above. So if you're at 80% or below, it's not going to have enough to do the program for you, so you need to plug it in. But it's at 99 right now. Oops. Somehow I jumped. Here's where the audio is. You can turn the audio on or off. Hitting it again gives you compliance data. So if I hit the arrow, because it's showing you an arrow, that tells me 16 hours, 20 minutes, and it's been used 23 times. So if you were checking on a patient to see what their usage was, that's where you would do it. And then you hit the program button one more time, and it's going into the mode of where you do the therapy. Okay? So now we have to set the stem. That's the first thing you do after you put the electrodes on. So you're going to want this, it starts out at 0, you're going to want this to be at 12 milliamps or above. There isn't really an average of what a patient is. It just depends on what you can get a good contraction out of them. If it's just a little bit and you're not causing them any pain and they don't really want you to do it, at least you've got some and you can build from there. So do it slowly. I kind of jump up to 12 quick, and then I go a little slower after that. So we are at 12 right now, and we should be able to see some contraction here. There we go. Get it a little bit higher. That's good. We'll stay with that. Okay, so if you hit the program button again,
Relax.
we want her to relax. So right now, I just want you to focus on your breathing in and out. Put everything out of your mind. We want to get your background muscle noise nice and level on the screen.
Ready.
Even though it's in ready, I don't want you to start thinking about anything yet. So if you'll notice the screen, it's just picking up, your muscle has noise coming out of it. That's what we're seeing on the screen. The more relaxed you can get and the lower you can get that, the better. So we'll just let her relax a little bit more. So it's picking up her movement, so we want her to be real still.
Oh, I just moved my arm.
Yeah.
Okay, that's fine. Okay.
Relax.
Okay. So if you can see here, the threshold came way down. It's realizing that she's having a difficult time. And
Ready?
we actually need that.
Good.
The threshold is not, is it buzzing you pretty good?
Yeah, oh, yeah.
Is it hurting?
No.
Okay.
Not at all. It just,
Relax.
I think, when you stimulate it, it doesn't relax as quick.
Yeah. All right. Close your eyes. We're not actually getting you very calm right now. So without moving your hand, this is okay. I want you to start thinking about, because we got you pretty low right there. I want you to start thinking about something that you're going to do with your hand. Something you do right now that really causes you to visualize something real in your mind. So what are you thinking of?
Kind of climbing a cliff and just grabbing the rock.
Okay, open your eyes and look at that visual on the screen. And imagine that this is the rock, and I want you to be reaching up and grabbing the rock, okay?
Good.
Good job. Sometimes that is what will make a patient go over the edge. It's just seeing something in front of them to actually, so you can, sometimes it's easy for a for a patient to visualize something, sometimes it's not, and sometimes they just need a little visualization for reals to be able to put them over the edge. So you came way down here, so that's good. You must
Ready?
be anti-stress since you passed that first little section. Okay, let's do that again. You have some real nice straight muscle noise there, so let's go ahead and do it again.
Good.
See how easy it is for you now? Sorry, we might have a little the flopper.
Pretty stimulating. I had the rock and then I fell. No, but yeah, no,
Okay, let's do it
actually-
one more time. See, we want it to get nice and flat. Okay, go ahead. And I want you to just reach up and grab that rock and fling yourself over the top.
Good.
Do you guys see that difference there? Now see, that is what you want. You want that nice low stuff and then real differences. I mean,
Relax.
she's got real good visualization, so that's perfect. Okay, we'll switch out. Good job. So thank you so much for allowing me into your facility. I appreciate your time. I really, really want you to work with as many patients as you can during this month trial. It's 30 days, but then I actually build 15 more into it. So at the end of 30 days, when you have the option to buy or not buy, and I know you're going to because you're going to see so many good results with these patients, that you can start the PO process and I won't take your device while you're doing that. So appreciate you so much. Call and ask questions. You guys have my emails, you have my cards in there. If you have anything that comes up that you don't understand, I'm happy to talk to you. So thank you very, very much.
Thank you. Thank you.